Hi, and welcome to a review of arterial blood gases. As you know, the components of pH, is a representation of hydrogen ions as a concentration in the blood. You need to maintain a 6.8 to 8 level pH to sustain life. Normal is 7.35 to 7.45. Staying within that very narrow range is really one of our goals of monitoring arterial blood gases. A carbonic acid formulation or formula is a representation of ventilation. CO2 and H2O or water combine to form a weak acid. And then and control is the primary function of the respiratory system, at least initially. Bicarb or HCO3 is a representative of the metabolic processes that take place. Kidney takes CO2 and water, and the hydrogen ion is cleaved from the bicarbonate and excreted as an acid. And in the case of alkaline excess, bicarb is excreted. Respiratory system acts in minutes. It's only effective for 12 to 24 hours. It excretes excess by blowing off CO2. The renal system, slower hours to work and continue for days or longer. So when we're talking about compensation, which you're not going to be accountable for at this point, you'll talk about it some in adult health too. You're really looking at compensation taking place over time by a metabolic system where hydrogen and or bicarb is excreted in the urine. Imbalances occur when compensatory mechanisms fail. As you know, you can have a respiratory imbalance or a metabolic imbalance. In respiratory, you want to think about our carbonic acid concentration, and in metabolic, you're thinking of bicarb. So metabolic, bicarb's your focus. Types of imbalances, as you well know. Metabolic acidosis, alkalosis, respiratory acidosis, and alkalosis. In respiratory acidosis, the causes are going to be lactic acidosis. This is your typical acidosis related to say a runner or a marathoner doesn't take in enough water, and you're generating metabolic or lactic acid as a byproduct of anaerobic metabolism because of the overuse of muscles and the lack of glucose in some of those cases. In ketoacidosis, you should be familiar with this because of we looked at this in depth in diabetes, in type 1 in diabetic ketoacidosis. Salicylic toxicity. You see this in like aspirin overdose. You'll see in a metabolic acidosis, at least initially. Methanol ingestion, like varnish or shellac, as little as 30 mils, you can be fatal. This is a huge problem. Ethanol glycol or antifreeze solvents, 100 mils can be fatal. Unfortunately, it's bright green. It looks very attractive. It kills a lot of animals, and it's also a very high-risk product for children. It looks like it would taste great, and 100 mils can kill, less than that can actually kill a child. Decrease in renal function, you'll end up with a metabolic acidosis, or an increase in bicarb losses like you'd see in diarrhea or vomiting. We talked about that in the vodcast. What would the ABGs look like? You'd have a decreased pH, a decreased bicarb, CO2 normal in an uncompensated state, decreased in partially and fully compensated states. In a metabolic alkalosis, you're going to see a cause of excessive bicarb intake, I kind of touched on that in the vodcast. As a homeopathic remedy, or in the past for things like an upset stomach or GERD, people took bicarb, a couple teaspoons, and put that in water. Now, that as a naturopathic intervention certainly isn't bad, but in excess. Typically, you'd see this in someone who's got a bottle of Tums and they're eating 2 bottles of Tums a day. You might see that reflected in the metabolic alkalosis, as they're way overusing or abusing that product. Vomiting can lead to an excess in K and chloride depletion. Renin stimulation and decreased GFR will equal an increased bicarb absorption and decreased filtration. What would the ABGs look like? You'd see an increased pH, an increased bicarb level, and CO2 normal in an uncompensated state, or increased in a partially and fully compensated state. Respiratory acidosis. You're going to see the causes being a respiratory center involvement, lung disease, airway obstruction. This is really your quintessential, ABCs patient, where A is the problem, or B. What would the ABGs look like? Decreased pH, increased CO2, and the bicarb, it would be normal in uncompensated and increased in partially and fully compensated. You'd see those either beginning to increase, or they would have increased to compensate. In a respiratory alkalosis, you're going to see the causes as excessive ventilation, say hyperventilation due to anxiety attacks, and that's why I had people breathe into a paper bag, for instance. It's a sort of a positive feedback mechanism, and plus, when you're breathing into the bag, you're rebreathing CO2, so you don't end up in an alkalotic state. Plus, I think there's a biofeedback to breathing into a bag. Hearing the bag inflating and deflating, I think, causes the feeling of a person cognizant of their breathing rate, and you can help to alleviate anxiety. Medical ventilation, which is or improperly in set mechanical ventilation, can cause alkalosis along with fever. What would the ABGs look like? Increased pH, decreased CO2, and a bicarb that's normal in uncompensated, or decreased in partially and fully compensated. A mnemonic for acid-base imbalances is ROME, or ROME. In respiratory, you're looking at the pH being elevated, where the CO2 is decreased in the alkalosis versus the acidotic state. And in a metabolic, it's equal, that the bicarb and the acidosis, and the bicarb and the acidosis in an alkalotic states match. All right, let's get to the crux of this, and that is ABG interpretation. You've done these before successfully in patho, so this is just going to be a brief review, and this shouldn't throw any of you for a loop. First of all, you're going to evaluate the blood pH. Is the pH within the normal range, 3.5 to 4.5? If so, it's either normal or compensated. Does the pH tend to be on the acidotic or alkalotic side? 7.4 is exactly in the middle, so is the value between 7.35 to 4, or between 4 and 4.5. Is the patient acidotic with a pH of less than 7.36, or alkalotic with a pH greater than 7.45? That's the question to ask. Evaluate the PaCO2. If the PaC2, or the partial pressure of carbon dioxide, is normal, is between 3.5 and 4.5. It's below 3.5, it's alkaline condition. If it's above 4.5, it's an acidotic condition. Evaluate the bicarb. If it's normal, between 22 and 26. Is it above 26, indicating an alkaline condition, or if it's below 22, it indicates simply an acidotic condition. Put it together. Ask which component, the CO2, respiratory, or bicarb, metabolic, and it matches. Does it match the pH acid-base state? and then decide if the patient has respiratory acidosis, alkalosis, or metabolic acidosis or alkalosis. Assess oxygenation status if the patient's normal or hypoxic. Then remember the values for PO2 and different for SaO2, or the oxygen saturations you're going to get from a pulse ox.